Okay, it looks like we have many participants, so welcome everyone. I will proceed even if others are joining us for a moment because people want to hear from our speaker, not so much from me. I'm John McLaughlin. I'm the Executive Director of CanPath, which you'll hear more about today. Some of you may be very familiar with it. I'm also a professor of epidemiology in the School of Public Health, the Dalla Lana School of Public Health at the University of Toronto. So welcome to all of you, and thank you for joining us on this webinar. There are a couple of housekeeping points that I'd first of all like to mention. There will be a Q&A presentation part to the seminar after the formal presentation. So if you have any questions, please put those, use the Q&A button at the bottom of your Zoom window. If we don't get through to answering all the questions, we can follow up, or you can follow up with us through either info@canpath.ca, or if you're interested as a researcher to learn more about accessing the data, we will also provide the link later in the chat so that you can contact access@canpath.ca. And then there are the usual ways to stay in touch with us, which we welcome, Twitter, LinkedIn, Facebook, etc. Before proceeding, I'd really like to acknowledge that the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples. And these are the territories on which CanPath's National Coordinating Center at the University of Toronto now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. With CanPath teams also working across Canada from coast to coast, we acknowledge the ancestral territories that are the home to many Indigenous people from across Turtle Island, and we are grateful for the opportunity to work on this land. Now, turning to today's webinar, it's my distinct pleasure to both be with virtually with Darren Brenner and also to introduce him. Darren is, Dr. Brenner is a molecular cancer epidemiologist and data scientist in the departments of oncology and community health sciences at the University of Calgary. He's also director of research at the Forzani and MacPhail Colorectal Cancer Screening Center and the associate director of Oncology Outcomes Research Initiative. Dr. Brenner leads a research program at the University of Calgary that focuses on big data, precision health analytics to examine cancer risk and outcomes. He also has, he leads several projects focused on the intersection of lifestyle, genetics, molecular pathways in the development of several cancers. And he's also currently the co-chair of the Canadian Cancer Statistics Committee and advisor for OncoSim. Today, we'll hear about some of that work on early breast cancer. So I will now turn it over to you, Darren, and thank you again for being here. And I'll speak with everyone again later as the Q&A comes up. So over to you, Darren.
Thank you so much, John, and thank you for the invitation to share some of this work that we've been doing here in the team in Calgary. So I was putting together these slides over the past few days, and I was kind of reflecting on when we started this work and all the amazing and life-changing things that have happened since 2018 when we started this work. So obviously COVID happened, and I was looking at some of the papers and the analyses, and I thought, well, we have a different team, and a lot of the people that were involved in a lot of this work have moved on and were engaged in various positions in public health in the COVID response. We're in a different building, different spaces. I feel like a different person. We've, pivoted some of the research we've been doing to address some of the, impacts of COVID on cancer control. But then when I come back full circle to this work, I realized that this question remains equally important. And the issue of early onset breast cancer is equally, if not more important now than it was before COVID. So despite the interruptions, despite the sort of pivots and changes to the world around us and sort of the things we've been doing over the past few years, this question remains exceptionally important. So I thought that would sort of set the stage for today. Not knowing exactly who's in the audience, I thought I'd start sort of very high level to discuss the overarching epidemiology of breast cancer, and then sort of talk about there's a story within the story of breast cancer in Canada, and this population of these early onset breast cancer patients, and then talk about how we've been able to use and leverage the CanPath infrastructure and framework to start to answer some of these interesting questions and important questions around the etiology of early onset breast cancer. And then how are we trying to sort of take this further and use this CanPath research to try to get even deeper into the details, the next steps and next studies that we'd like to do in this clinical population. So as John mentioned, over the past few years, I've had the distinct pleasure to serve as one of the co-chairs for the Canadian Cancer Statistics Advisory Committee, which is a collaborative endeavor led by the Canadian Cancer Society, Statistics Canada, the Public Health Agency of Canada, and the Canadian Partnership Against Cancer. And as part of this work, we do our best to try to understand, model, and project the cancer trends in Canada. So incidence, survival, prevalence, mortality, and try to understand what's happening and to describe and provide up-to-date data for the cancer control community. And so as part of this work, we tuck really deep into the details across different cancer sites and across different age distributions. And what I've sort of noticed several years ago, for many of the common cancers, including breast and colorectal, there's really a story within the story where when we look overall in the population, cancer control efforts have been working. We've been reducing the age standardized incidence rates of mortality of cancer, lowering incidence rates, but yet in certain age groups, certain populations, we see these paradoxical trends where we see increases in risk, we see reductions in outcome, reductions in mortality, and early onset breast cancer is one of those groups where despite making progress in the overall population of breast cancer patients, in these early onset patients, we see a different story. So hopefully that sort of sets the stage of why we're interested in this population and how we sort of set the way down this path to this research project some 5 years ago now or so. And so just to sort of do a level set where we all are in terms of the epidemiology of breast cancer. So these are from 2021 data from the Canadian Cancer Statistics publications. And this is sort of a sneak peek that here in the team and collaboratively with the partner agencies, we're working on a data dashboard, and these are some early captions from it. But what this allows us to show is on the left that breast cancer is indeed the most common cancer among Canadian women. And breast cancer remains the second leading cause of cancer-related mortality. And this is shown on the right as a function of total cancer cases and total cancer deaths due to deaths due to cancer on the left and right. And so, as I said, we've been making a lot of progress as a cancer control community in the breast cancer landscape. I think the clearest example of this is looking at age standardized mortality rates for breast cancer. So we look back over the past 40 years, what we see is a pretty remarkable story of about a 50% decrease in age standardized mortality rates. So an age standardized mortality rate, for those who might not be aware, basically is a way to account for the age structure and changes in age and changes in demographics over time in a population to be able to compare apples to apples, year to year to year, to know sort of accounting for changes in the shape and size of the population, what's actually happening. So here we see that, about a 50% decrease in the number of Canadian women that have been dying on average over the past 40 years. And this is, in due in large part to advances in screening, early detection, improvements in surgical techniques and radiation and systemic therapy. So excellent story. We hope to keep seeing these trends decrease. In terms of incidence, there was, an increase in the late 80s and 90s, but largely rates have stabilized in the overall population over the past 20 years. And again, these are age standardized rates, so comparing apples to apples year over year in the Canadian population, accounting for changes in the age structure and size. But when we look at this sort of on an age specific data, it's a little bit of a different story. So as I mentioned, there's a story within the story. And so these are similar data from 2021 when we look by age groups in Canadian population. So 0 to 14, 15 to 29 years of age, 30 to 49, 50 to 69, and so forth. And I'll draw your attention to the 30 to 49 bar, where breast cancer is by far the most common cancer among Canadians under the age of 50. And when you account for that total 0 to 50, it's about 25% of all cancer diagnoses in women are breast cancer. And so the definition of early onset disease differs depending on the clinical categorization, the group that's presenting the data, or who's discussing the topic. Some say it's less than 39, or sorry, less than 40, and sort of follows more closely around an adolescent and young adults definition. And some say that it's less than 50. And I kind of tend to lean towards this description as early age onset, because it relates more closely to the debates around population-based screening with mammography, and also for all of these cancers that we're sort of referring to as early age onset, because it's largely diagnosed before people would be eligible for screening in most Western countries. I think of these as happening early in the life course compared to the overall distribution of the population. So if we're out throughout the presentation, I'll sort of refer to early onset as less diagnosed before 50 years of age. So just jumping back to all those trends, we see sort of stabilization, improvements in incidence and mortality. We don't necessarily see that for this early onset group. So we know that it's quite a considerable population. And is it growing? It seems to be increasing in this age group. And so these are data from the United States. And so this is from 2004 to 2017. And we look year over year, not just are all cancers, breast cancers among this age group increasing, but also invasive breast cancers increasing. So it's not just that early stage cancers, potentially picked up through, going to see a GP and then going for some screening is picked up. The invasive cancers are also going up. And there's also a statistically significant increase in women diagnosed before 40 and before 50 who have distant metastases at the time of diagnosis. So again, story within a story, there's something different happening. And that's what we see in the United States. And we also see it here in Canada. And so these are some data that was done by Emily here and Yibing Ron in our group. These are slightly out of date now. The data go up to 2015. But what this is a birth cohort analysis. And this is a way of evaluating the rates of a disease over time based on when somebody was born. So each of these points represents a 5-year birth cohort. So basically being born between 1935 and 1940, 1940, 1945, and so forth, and allows you to get a sense of trends over time. So we see, now these are Canadian data, that after 1960, we're starting to see more dramatic increases in these rates. And while it's not significant, we're going to update these analyses. We suspect that it will be, and this will continue to increase based on rates we see from the US and from other groups. So indeed, story within a story, it's changing and it's increasing here in Canada. And so it's not just that the incidence is increasing, whilst that is extremely important context for the story. It seems like what we saw in the United States, these patients have adverse molecular characteristics at the time of diagnosis. So early onset patients are more likely to be diagnosed with triple negative breast cancers than those diagnosed at later age groups. They have consequently comparatively poor outcomes because oftentimes they're not diagnosed through organized screening programs. And so the consequence is that they're diagnosed at a later stage more often and have later stage adverse molecular characteristics. And so they have adverse outcomes. And so it's a very important clinical question, but it's also, a societal and population health issue. This population of women has considerable impacts on the life course based on the time that they're being diagnosed, disruptions to the family, and not to mention economic impacts and disruptions based on a high proportion of women being diagnosed with aggressive cancers in early life course years. So hopefully this sort of imparts that two things. One is a story within a story in terms of breast cancer in Canada. And two, this is a really important clinical but public health question. And this is starting to get quite a bit of attention by the provinces' screening programs. There was a really interesting analysis that came out, I think, just a few weeks ago in Current Oncology that was led by some of the team in the chronic disease branch at Statistics Canada and some clinical colleagues from Ottawa that evaluated the actual impact using real data here in Canada, where there are some opportunistic and some sort of partial screening programs among those women aged 40 to 49 in Canada, and compare diagnostic rates, stage of diagnosis rates with provinces where they have 50 to 59. Very compelling data, very interesting paper. If anyone's interested, I would urge them to have a look. And actually just this past week, this announcement came out that for all women, not just those of high risk or having a family history, in Alberta, they've now dropped the age to 40, 45 from 50, and they'll keep evaluating over time to see how this has an impact in terms of incidence, mortality, stage of diagnosis, and then potentially even revisit to keep that going lower. So very important clinical population health issue, potentially important to sort of continually be updating these guidelines. So screening and clinical outcomes are one side of the story, but what might actually be driving these changes in trends? What do we know about the risk factors and what could potentially be leading to these increases in early onset breast cancer? So from the epidemiologic literature, we know quite a great deal. There's been lots of studies that have been done, large population-based studies to evaluate what increases risk in the overall distribution of breast cancer patients. So we know that there's quite a few modifiable risk factors that have consistent associations, some with systematic reviews and consistent evidence, sort of using things like the IARC framework for carcinogenicity. We're able to quantify the burden that this has on the population and the potential impact for prevention. And so, highlight here some of the work that we've done with this CCS as part of the Canadian Population Attributable Risk of Cancer Project. If anyone's interested, I would urge people to have a look. It's really nice knowledge translation materials that we generated here at prevent.cancer.ca. We also know that there's lots of many non-modifiable exposures that we've been able to characterize and understand about sort of what increases the risk, but then there's also a large proportion of unexplained risk for breast cancer. We don't necessarily have a good sense yet about what's driving early onset rates, and we don't even know, are these the same risk factors as we see in the later stage populations? And so we know that only a sort of small proportion of breast cancers diagnosed among younger or earlier age women are attributable to known genetic factors or mutations. And so this suggests that there is, a meaningful environmental and lifestyle factor, and maybe these increasing rates are being driven by some changes in the epidemiologic profile of the Canadian population and Western populations. And so I included this schematic here. This is something we put together for the Canadian Population Attributable Risk of Cancer Project to sort of drive the point home that, well, why would we do these types of studies? Well, we don't know what we don't know, and we can't make any change. But if we can understand what is increasing risk and do the epidemiologic studies to understand risk distribution, we could then potentially try to make some changes at the person, the practice, or the policy level to try to change these curves, flatten the curves, or reduce them going forward, as we have been able to have progress in cancer control for some of the older age populations. So I think the same paradigms for prevention are potentially applicable here for this early onset population. So we know there's a story within a story. This is an important clinical and population health question, but we don't know sort of what is driving these risk factors. And we know that there's sort of a question of, are these the same? Are there novel factors? And so this is what sort of led us to start thinking about how can we answer these questions. And we're really fortunate to, be here in Canada where we have access to things like the CanPath studies and cohorts. So for those who are unaware, but I assume there's probably a small population who are unaware, the CanPath, I would call it a collaborative consortium of cohorts, so a little alliteration there, that aims to understand the determinants and the distribution of health and disease in the Canadian population. And so we set out to sort of say, okay, well, this is potentially one way we could access some data, try to understand what are the risk factors that are potentially driving these changes in risk in the population. And so we worked with 3 of the partner cohorts from CanPath, the BC Generations Project, Alberta's Tomorrow Project, and the Ontario Health Study. We completed our ethics and submitted data applications for each of these cohorts to try to ask for data on any early onset cancer patients, breast cancer patients that have been diagnosed post entrance to the cohorts, and then can we match them with some non-cancer or healthy controls to sort of put together a sufficient sample size to answer some of these questions, or start to answer some of these questions in the Canadian context. And so we worked with the 3 cohorts, so moving from west to east, BC, Alberta, and Ontario. We were able to put together a pooled sample size of 609 cases of women that were diagnosed with breast cancer before the age of 50, who had sufficient follow-up time to be included in the analyses, and then pooled them or matched them on a 3-to-1 with healthy controls to conduct these analyses. And we tried to, wherever possible, match these based on age of entry to the cohort and how long they had been followed up in the cohort, to try to do our best job to sort of properly estimate risk related to these exposures in the population. So the stage was set. We now had sufficient number of cases and controls to be able to compare the relative proportions of those exposed, previously exposed to these interesting risk factors amongst cases and controls, and conduct some statistical analysis to be able to estimate parameters of risk. So thankfully, in the cohorts, there was the foresight years ago to try to standardize as best as possible these data collection tools, which made our life much more manageable when trying to combine and consolidate these different variables and exposures across the cohorts. So having a unified health and lifestyle questionnaire was exceptionally helpful. And all of the cohorts have taken the initiative to link the participants in the studies with the cancer registries in each province. And as a cancer epidemiologist working in Canada, I feel exceptionally fortunate to be working here, where each of these provinces has high quality cancer registration data. Over 99% of cancers are collected, are captured in these data with all kinds of detailed follow-up in clinical data. So really rich resource to conduct these types of analyses that's really been paved by the CanPath framework. So I won't go into detail of each of the exposures. I invite you to investigate our paper if of interest. It was by Pater et al. In 2021, but we did look at most, pretty much every lifestyle, behavioral, dietary, reproductive, health, and measure of SES that was available in these questionnaires. And wherever possible, we try to standardize the definitions to relevant guidelines or categories of risk exposure that are used by groups like Public Health Agency, chronic disease agencies, or WHO, so that they sort of had a direct interpretation of the results. So I'll go through some of these results from the various exposures and try to just highlight those that were of most interest for taking forward. If someone's unfamiliar with one of these plots, this is called a forest plot, where on the bottom axis is your measure of risk. On the y-axis or the side are the exposure categories of interest. Each of these is compared to a reference group, so comparing to something lower than the next group down. And the red dotted line is the null value. So basically, if the point estimate is the square, which is the sort of, in this case, odds ratio estimate, and the confidence band is shown here. If it does not overlap with this null value, suggests there's a statistically significant increase, but in this case, not always necessarily having to be statistically significant, where sample sizes may be small, but it gives you a sense of the relative precision of the estimate and also the impact of the estimate. So here I'll highlight that there seems to be some indication that measures of SES are associated with increased risk. I'll show on the next slide as well that income seems to be important in addition to education. Has been previously reported for later onset cases. The total number of pregnancies and reproductive factors seem to be statistically significant, with higher numbers of pregnancies being protective. When we look at things like smoking and alcohol, not necessarily sort of jumping out as prime drivers of risk. again, measured the socioeconomic status, with those at lower incomes being having higher incomes having a lower risk. And then we look at additional reproductive variables. The highest risk factor we saw was having a family history of breast cancer, with almost doubling in your risk of having a diagnosis of breast cancer in the cohort before the age of 50. And very interesting results when we start to look at the measures of excess body size and energy balance. So physical activity and BMI and waist circumference. So there's been this sort of paradoxical finding in premenopausal breast cancer studies where those who have higher BMIs have a protective effect, something having to do with body levels of adiposity affecting menstrual cycles and the regularity of those. But then when we look at waist circumference, having a high waist circumference or a high waist to hip ratio is statistically significantly increasing risk. So there's something about energy balance and the distribution of adiposity that seems to be important in the prediction of early onset breast cancer risk. And this is actually congruent with studies that have been done in other geographies and in other early onset populations. So our initial interpretations of these data is that there's clearly something going on about energy balance. It's involved in the risk of developing early onset breast cancer, but it's a very complex story. We need to understand a lot more, and we need to do some additional research to really get to the bottom of what's going on. And I'll come in a few minutes to sort of what the next steps might be about understanding these associations. It seems that measures of socioeconomic status are important in terms of increasing risk for early onset breast cancer, and family and personal history of cancer and also chronic disease seemingly are very important markers of risk, and they may help guide decisions around primary care and how to sort of manage risk categorization and stratification for screening. But if anything we learned from this study is that there's a lot more to do. We need to understand a lot more before we can make any sort of concrete recommendations. So there's limitations we need to discuss in this particular research and in using the CanPath study here. So all of these data came from questionnaires. And so there's inherent limitations about using self-reported questionnaires. Do they actually reflect people's honest truth about their exposure status? Maybe they misinterpret or misrepresent the question. And are they actually representative of their habitual exposure over time, or more so close to the actual time the questionnaire was measured? We kind of have a truncated population here. We're interested at risk on this side of the distribution of age among adults, but because people were only really started being admitted to the cohorts in their late 30s and 40s, we kind of have, that would have been nice to, if, for these types of studies to start recruiting people in 16 and 18 to have a real, a true distribution of the early onset population. But nevertheless, it's still a unique resource to even be able to answer these questions. And the question around time. So a lot of these questionnaires were developed in the early 2000s. And the designers of the questionnaire did the best at the time to sort of think about what could be of interest and what is of interest in terms of someone's exposure. But a lot has changed since then. I think the iPhone came out in 2007. So, life has changed a lot since the time of the initiation and development of these measurement tools. And so lots going on. When we see this acceleration of risk, we think about, there's probably lots of other novel exposures that are driving risk and may be driving risk, but we need to think about how do we measure these factors. When we think about life now post-COVID, we have a whole new set of exposures and a whole new way with which we interact with the world around us. I mean, I'm sitting all day now, which is not the most fun, but I think it's representative of lots of people's realities now, where they used to be much more sort of passively active. As I said, cell phones and the interaction with digital technologies has changed dramatically since the recruitment of patients from the study, or recruitment of participants in the study, and the collection. All kinds of novel medications have come to bear. Chronic stress, I think, is of high interest to myself and to the changing population with the seemingly increasing prevalence of mental health issues and just chronic stress. And then there's sort of all of this new biochemistry related to new consumer products here. These are microplastics, and just sort of thinking about, there's lots of things that change year to year as we go, and how do we do a good job about thinking about, are these important in terms of our individual cancer risk and collectively from a public health perspective. So we kind of have been working since we finished that study, thinking about how can we use these cohorts to better understand these associations. So not necessarily a clear story from this first analysis within CanPath. We see some confirmation of some previously observed associations in the later onset groups, but there's also sort of a lot more to do, and how do we have confidence in what we see from our associations. And so we've conducted a study. This was done by Tiffany Price as part of her master's project, where we, taking one of the three cohorts we were using, in this case, the Tomorrow Project in Alberta, we looked at some circulating measures of inflammation and insulin resistance. We were interested in these two particular sets of biological markers, as we clearly saw there's something about energy balance, body size, distribution of adiposity in the breast cancer story. And so here in the study, we did this just in Alberta, and we started to look at, well, can we have additional belief in these associations when looking at the biological markers? So using biological circulating markers to understand these associations. And so we looked at C-reactive protein as a marker of inflammation, which is related to increased adiposity, to decreased activity, sort of the negative side of the energy balance equation. And looked at hemoglobin A1C as sort of a marker of insulin resistance, glucose dysregulation. And we found a really strong association actually for having anything above 0.6 micrograms per liter of C-reactive protein. That was our reference group in this case. And again, this is a smaller sample of patients. And we see this, we had to do among all participants or all breast cancer patients in Alberta. We weren't able to do it just among the younger onset because of sample size constraints. But when we look in subgroups among the younger population, we see consistent effect estimates for this. So it seems that there, adds validity to the finding that something about energy balance is extremely important for early onset breast cancer, as well as the later onset distribution. So what's next? So, well, there's lots of things, as I mentioned, that we haven't not yet measured. We are interested in all of these exposures, but how do we even think about trying to measure them and trying to understand if they're related to increased early onset breast cancer risk? One of the approaches I'm really interested in is, can we use the genome to identify causes of cancer, things we don't know? Can we sort of use it as the tome of exposure and understand using the genome to know this? And so there's lots of work that's been done on something called mutational signatures. And so just like everyone's individual handwriting and signature is unique and tells us something about them, and we can use signatures, we can use tendencies and signatures to know if it's a real signature, or in this case, a counterfeit signature, and someone trying to sell a Mickey Mantle baseball card when it's a counterfeit. We can use these to try to think about a similar approach using genomic sciences to understand cancer risk. And so this new approach called mutational signatures has sort of become increasingly popular over the past 5 years. And so we were doing some of this work in pre-COVID times, and we hope to continue this forward now that things are sort of returning to some normalcy. And so what we do when we look for mutational signatures, we take samples from patient's blood and from the actual tumor. We sequence them using next generation technologies, and we look to see differences in the underlying DNA, DNA sequences between the tumor and between the blood. Then we can, thanks to high pollutant and high capacity bioinformatics, understand, well, all of these huge amounts of genomic data down to look for signatures. So different relative frequencies of types of changes in the DNA from what you were born with to what your tumor has, and understand that something caused those changes. Because at its root, cancer is a genomic disease. And so we assume that all of those risk factors that we've been studying and understanding at the very end have to have some impact on the genome. So this is one example of signature 4 from the COSMIC catalog, which is sort of an online repository led out of the United States to try to pool together all of these data to understand the common signatures and signatures and mutational processes in cancer. And so signature 4 is related to known tobacco exposure. So this shows up a lot, for example, in lung cancers and squamous cell cancers of the lung. And so there's quite a few others that are starting to emerge with these bioinformatic groups to try to help us understand, well, can we look backwards? So can we start with the tumor, start with the biological samples and see, are there any different exposures? And so the question would be, well, how would you do that? You would look at later age onset cancers and early onset cancers and see, are there any differences? And so we started doing that, and this is work that was done by Nicole Mealy and our group, who's now since moved to the United States, where we did some pilot work with publicly available data sets. So this is from the Cancer Genome Atlas, where here, these are later onset breast cancers. So each color represents a contribution within tumor. Every single bar is an individual cancer patient. And then the colors in each bar represent how much of that tumor shows up with those relative signature contributions. So the higher proportion of the color, the more that's the predominant signature within that tumor. So in lung cancer, you'd see a lot of dark colors for signature 4, for example. And so we look at later stage patients, and then we look at a sort of smaller sample of early onset breast cancer patients. We do see some meaningful differences. When we do some additional analytic approaches, we can start to see some signals here that there may be some things going on. And we also note that we see a different proportion of triple negative cancers. So we see gross morphologic differences and genomic differences, but then also the very nitty gritty, looking at this at a very deep level from bioinformatics, you start to see differences. And one other observation we had from this work was that we see significantly higher numbers of just sort of basic changes from C to A's in early onset patients than we do in later patients. And so all of these sort of early signals give us additional weights to our hypothesis that there is something going on and there's different processes that's driving cancer risk in these early onset groups compared to later onset patients, and that the increasing trends may reflect some different exposure. It may reflect a different intensity of the same risk factors that we see in later onset patients, but it implies that there's something different that's going on. So when we look at the epidemiologic data from cancer trends, we see there's a story within a story, and this seems to be supported from some risk factor data as well as from some molecular and genomic data. So those are all publicly available data that we looked at from the Cancer Genome Atlas. So what's next? So that was a sort of a good starting point to sort of see, do we see some differences? You know, it's really interesting. There's not much clinical data, but there's no exposure data. So just because we see something doesn't mean we can sort of try to start looking at what's causing those differences because there's no exposure data. We've taken this one step further. We're now doing some additional pilot studies from the Alberta Cancer Research Biobank here in the province, and we've sequenced another 100 early onset breast cancer patients where we have really good clinical data, and we have some exposure data, not ideal, but we have some basic exposure data from clinical notes. And then we can also, so we'll take this next one step further, and this is work that one of our PhD students is working on right now, hopefully have it finished next year. And then maybe we can work with resources like the Canadian Partnership for Tomorrow to start collecting additional tumor samples to pair with the blood samples, other really well-developed cohorts like the RUBY study, the Reducing the Burden of Breast Cancer in Young Women study, which is led by Steve Narod and Maylin Kwan here in Calgary, where they have over 1,000 early onset breast cancer patients where we have blood and tumor, and we have lots of epidemiologic data. So this may be sort of, how do we actually start answering some questions, or how do we provide the adequate answers to these questions of, is there something novel How do we understand? How do we use the genome as the roadmap to understand what's driving the trends? And then take it all back that if we understand that something's happening, something's driving risk and exposure, we can then plan for it to try to make impact at the person, the practice, and the policy level to try to drive those trends and those overall incidence and mortality curves among early onset patients back down, as we're seeing for the older onset patients. So to tie this all together, I hope I've sort of articulated the case that this early onset breast cancer is a very important clinical and public health issue, that we really are fortunate to have been able to leverage the CanPath framework that's allowed us to sort of have these initial studies and also with large populations with quality collected data to answer some questions, etiologic questions about cancer risk and its distribution in the Canadian population. We know that we're sort of taking this further to try to understand and add additional validity, etiologic research to confirm what we know about these sort of known associations like excess body size and family history, but then also hopefully examine some novel exposures using some of these more novel genomic approaches like mutational signatures, where we can have continued studies of the environment and the genome. How do these impact risk? How do these impact cancer outcomes as well, sort of post-diagnostically? Can we use these in any kind of meaningful clinical way to guide clinical management? And a lot of this will then also hopefully impact future decisions around screening guidelines. If we understand who's most at risk, we can do a better job of refining risk categories, refining programs, and predicting those who may most benefit from early detection and screening programs. And then we'll also be continuing to examine the trends and hopefully see them reducing over time as we maintain our cancer control and surveillance efforts in Canada. So with that, I just want to thank a lot of people. I've been really, really fortunate to have lots of great trainees and team members working on all of these different papers and projects in the pre-COVID times when I feel like I was a different person. But also, really happy that they were able to use these data as well to move forward and use the CanPath to sort of help enrich their experience and their training and answer some important questions. Acknowledge the team here in Alberta from the Tomorrow Project, who's been really helpful and instrumental collaborators for a lot of the work we've been doing. The teams at the PC Generations Project, Ontario Health Study, all of the CanPath participants. Without them, none of this is at all possible. And then all of our different funders and collaborators from the national agencies, and here in some in-kind support from the Arnie Charbonneau Cancer Institute. So with that, I will pass it over.
Darren, thank you ever so much. That was a tremendous, tremendous presentation of many years of work that was really brought together into a very thorough program of research and thinking. So thank you on that. There are quite a few questions in the Q&A that, and I will go through those. Others are welcome to add questions. I'll start with one that I think you've partially addressed in your later slides, but Joanne Kutsopoulos has asked the question about, this was more the descriptive epi part at the very beginning, but your thoughts on whether any of the change in incidence in early onset breast cancer would be attributed not only to screening, as you referred to some of the papers, but screening amongst high-risk families of young women from high-risk families. Any thoughts on that?
Thanks for the question, Joanne. So if I understand correctly, sort of how much of the changes and trends would be due to screening programs before age 50, particularly in Ontario's case with high-risk families?
Right. So you did comment and give some evidence about the impact of screening, but given the fraction of women who would actually be high risk or from high risk families, do you think that that relatively small fraction could still give rise to some of the increase in incidence?
It's possible, but I would suspect that it's likely due to sort of underlying shifts in risk. you'd likely, so once those population groups kick in, population screening programs kick in, you might see an increase, but then a drop off. And this sort of seems to be steady over time over the past few decades. So I would kind of argue that it's likely that there's some epidemiologic shift that's going on that we should keep thinking about, and whether the result is, changes in screening guidelines for more people, not just high risk families and women, but it's a really important to keep surveilling on these trends.
Yeah. Thank you. The next question is, and partly this might be whether or not you've been able to find any data to actually explore it, but the question is whether early onset cancer, breast cancers, could be associated with some ingredients in conventional personal care products and makeup. I think I know the answer given our questionnaire, but over to you.
I haven't found any sort of what I would call strong evidence in either direction. We don't know if it is, we don't know if it isn't, mostly due to a lack of data. There's, I think, individuals, research groups that are really interested in this and sort of looking at water samples from municipal sort of wastewater to sort of see, are some of these things showing up in the water, and how does that affect breast cancer and other early onset cancer rates? But I haven't seen sort of strong data yet. That doesn't mean it is, it doesn't mean it isn't.
Thank you. Several people have given nice commendations for your excellent presentation, followed by a question here. What challenges did you face when applying for the data from the 3 cohorts?
None. They were excellent to work with. Being facetious aside, it's just the time perspective. If we have your sort of ducks in order with paperwork perspective and ethics, and have a good team working with you to make sure all of those things are filled out in a timely way, we didn't really have any pushback per se. Just that it's just a matter of time and waiting for the various linkages. And when you ask for something very specific, like we did, which was sort of age and basically incidence density sampling, so matching based on time and age in the cohort, it takes a bit more skill and expertise to make sure that's done correctly. And then there's sort of a bit of back and forth to make sure that the data we received were the data that we really wanted. But otherwise, I wouldn't say that there was any necessarily roadblocks other than just the time it takes to do the paperwork, do the reviews. It's, everything is done in sort of triplicate when you go through 3 different cohorts. But if you're sort of perseverance and patient, that you'll receive it in time.
And I can add to your question to inform the audience as well that it is the intention of CanPath as a national pan-Canadian program to create a single point of access for researchers. And so Darren, I recall when you got the CIHR grant that I was hoping in 2018 that we would have that mechanism in place by now. But because the data are coming from the provinces, because the data really are essentially requiring the data of the each provincial cancer registry, you were absolutely right at the time to proceed by going to the 3 individual provinces. So that's an area of work that we're continuing to actively to try to resolve and address. And in fact, we do have a CCS grant with the PI Robin Urquhart, who's actually bringing together the provincial cancer registry linked data so that studies such as yours will be, in fact, a bit easier to implement in the future.
If I might just add, we have a similar line of investigation and work for early onset colorectal cancer as well. And I would note that even with the sort of constraints and demands on time during COVID, we still were able to receive data from various cohorts. So, commend that completion of that, even with the overwhelming demands for data analytics time during COVID.
Thank you. And another question: do you think the benefits of increased breast screening? Oh, it just disappeared. Where did the question go? Outweigh the negative impacts, such as stress caused by false positives? And then they also ask, could you say a little bit more about what energy balance is?
So excellent questions. Energy balance, in my definition, would be the balance between the physical activity, exertion, the amount of sort of ways you move your body through space in a day. So sitting time, active and passive physical activity, and then the energy intake from food and diet, and sort of the fine balance that we all have to strike with that throughout our lives of what we do and then what we sort of intake. So that's sort of how I would define the balance, and the consequences of that energy imbalance typically leads to excess body weight, body size, and metabolic consequences. In terms of the consequences of false positives in screening, it's an excellent question. I don't know that I have a really good answer, having not had lots of cancer screening myself. So I don't feel like I can adequately empathize with the sort of feeling of a false positive. I know there's lots of work underway right now to look at the cost effectiveness and cost benefit analysis of changing to different thresholds from 45 to 50 high risk to all work being done through through CPAC and other collaborators. So hopefully we'll have more good answers around the sort of cost effectiveness. But in terms of the individual piece around the consequences of an individual false positive, but then also the collective number of false positives, I don't know that I have a really good answer on that.
And I could also add from my own experience in running screening programs that there has been a lot of attention given to essentially the risk communication and that knowledge translation step up front to make sure that the expectations of what screening can do and cannot do, and then how it's communicated in a timely fashion. The organized screening programs, I believe, have really taken that on quite effectively, but there's still room for improvement, it sounds like. Geraldine has asked, do we know, or do you know, about anything about the menstrual cycles, such as ovulation for women who are getting early onset breast cancer?
Great question. So we looked at everything that exists in the questionnaire related to sort of age at menopause, age at menarche, number of pregnancies, things like that. We didn't have data to sort of map out a total number of cycles variable. We would have to make lots of assumptions that we weren't really comfortable doing. But if you want to have more sort of detailed data, I'd invite you to sort of check out our paper in terms of the individual sort of breakdown of all of the reproductive factors. And I don't know of any really strong studies that have mapped it out in that sort of total numbers of cycle detail for the early age population.
Right. So in studies that Steve Narod and I and many others have done for focusing on ovarian cancer, the focus on ovarian cancer was so clear that it was straightforward for us to include those types of questions about ovulation history, and in contrast, just for the audience to also recall that these population-based cohorts are actually looking at the full range of health outcomes. Cancer is one of them, but not just even one type of cancer. So it's one reason why the baseline questions were not going to cover everything that everyone would want to be interested. Along those lines, we are also able, with the cohorts, to go back to participants and ask additional questions or collect additional samples from them. So Darren, for you, what types of questions would you ideally like to see in the next round of CanPath questionnaires that are going out to each province?
Just consent them to their full Google life history. So we'll know everywhere they ever went, everything they ever did, everything they ever looked at. No, not being facetious. Some of those exposures around sitting time, I think, to me is very interesting. Just especially now with changes. I mean, maybe those who haven't yet developed cancer in the cohort, how we interact with our day has changed so much over the last 5 years and 3 years, and then sort of some of the more emerging exposures around mental health and how that seemingly has a pretty strong link with chronic disease, and I think that's also changing over time. And then also, if there would be a way to sort of have some access to the accelerometers / digital health monitors we all carry around us all the time, that would be very interesting.
That's a very good point. You did actually make that point in your presentation, how the information available and how it's collected or collectible is different now than when the cohorts were established more than a decade ago. Christina has asked the question, I realize the sample size is probably too low, but when you were looking at individual risk factors, including the forest plots, was there an attempt to look at the cumulative risk factors, since all the odds ratios are still very low? So that idea of kind of combining a constellation of risk factors, essentially my question is really, is there a panel of risk factors that would put someone at a much higher risk bracket?
Christina, that's a really great question. We did not look at that, but I'm now very interested to tuck back into these analyses and start potentially building a risk score. I think that would be very useful, particularly for some of those, what I would call easy to collect variables like family history, chronic condition history, reproductive history. Those things are reasonably well collectible at the point of care for a GP to sort of think about these risk stratification approaches for potential screening based on high risk thresholds. Great question.
Yep.
I hope you don't mind if I take that.
That's why we're here as a community working together. Geraldine has asked, increased waist circumference and insulin resistance seem to be involved. So accordingly, are rates higher in younger women with diabetes?
That seemed to be a signal when we looked at chronic conditions. Not statistically significant, but it seemed to be when we looked at sort of the reported comorbid conditions. But the issue is in the questionnaires, it would basically be a diagnosis of type 2 diabetes rather than lots of people have elevated HbA1cs in their 30s and 40s in Canada that we don't know if a physician may not have yet diagnosed them to be clinically managed for diabetes. So it's likely that the signal we see is sort of indication of those at the highest level of diabetic complications in the baseline of the cohort. And it might be that there's already sort of this shift that if we had a little bit better measure of those who may be sort of pre-diabetic based on HbA1c levels at baseline, might have been a stronger association.
Okay, thank you. One of the questions had a kind of a side comment saying about the sample size possibly not being large enough, but can you comment on, from your perspective, being able to do this type of work, kind of the significance or the relevance, I should say, of being able to have in your in the first part of your case control study over 600 or about 600 cases of early onset breast cancer. That was cancer before age 50, and then a group of 1,800 matched controls. Was that helpful for you in your career in epidemiology to have a resource that allowed you to have data for that type of group?
Absolutely. It was very helpful to sort of create a compelling question and the resource to do so, to be able to actually facilitate answering this question. If I had to build this homegrown or de novo here based in Alberta, it would take multiple years, many millions of dollars in research funding, and a whole team. And that's already sort of leveraging all of that investment, all of that work from CanPath already. And as I said, we're doing this in other early onset populations as well. It's a fantastic resource, and I feel very fortunate to live in a place where this exists and a collaborative research community that allows us to access and use it at reasonable access.
Thank you. So on behalf of everyone here, we applaud you, Darren, for this great work for you and your team. Thank you for the presentation today, the great program of work that you've led. To all participants still available here, please look at the chat for that contact information. And then finally, you'll also see a link to our next upcoming CanPath webinar in November. So thank you, Darren. Wish you well. Look forward to chatting again soon. And thank you all to all of the participants as well for your active involvement today. We'll finish up there. Thank you.
Thanks, everyone. Take care.